for asthma. Asthma, just now I said you asthma, it affects the bronchial muscles, thereby there will be a hyperpressure of the this is the lumen, okay, elastic basal lamina, you see bronchial muscle. Due to hyperpressure of the bronchial muscles, it constricts the lumen. Due to the constriction, patient will have difficulty in breathing, wheezing, that's all. Okay, this happens due to allergic. One is non-allergic. Okay, this is the point about asthma. Asthma is the chronic inflammatory disorder of the airways that causes recurrent episodes of wheezing, breathlessness, chest tightness, cough, particularly at night or in the early morning. This is how it presents. Asthma, the correct definition is, it comes under the classification of chronic obstructive disease characterized by trachea bronchial hyperreactivity to paroxysmal airway narrowing due to various causes, which may reverse spontaneously or as a result of treatment. Sometimes when he is having a kind of an allergic asthma due to an immune mechanism, or if he is going for a new home, new house, he will be having difficulty to breathe. Once he comes back, he will be normal. That is known as spontaneously, or else giving him inhalation drugs, then he will become normal. Okay, that is how the treatment differs. Asthma. Patient with asthma experience disabling attacks of severe dyspnea, cough and wheezing triggered by sudden episodes of bronchospasm. A state of unremitting attacks called status asthmaticus proves fatal. In the sense, a patient is having a continuous attacks of asthma. Okay, the terminology is known as status asthmaticus, and then patient may sometimes he may get collapse. Yes, yes, very good. Asthma classification will have a mild, intermittent, mild, then moderate and severe based on the frequency of the severe symptoms. Other clinical categories such as steroid dependent, steroid resistant, difficult and brittle asthma, in the sense who are all steroid, we have mild, moderate and severe type of asthma. Apart from that, those who are dependent on steroids, the main important treatment is steroids. So, the who are constantly exposed to steroids, those are we call steroid dependent asthma. Next, asthma, it affects 10% of children, 5% of adults. Half of the cases develop in patients less than 10 years of age. Two types are there, extrinsic and intrinsic. Extrinsic, it is an allergic, patient who is due to allergic asthma. Intrinsic is non-immune, patients having less immune factor. In extrinsic, it affects particularly children, young adults with atopic history, that is allergic history. Here immunoglobulin E and eosinophils will be increased in amount, whereas in intrinsic it affects adults with no apparent allergic diathesis. There won't be any allergic. There are two types of asthma there. One is an allergy, due to allergy, and due to non-immune factor, not due to allergy. Due to non-immune factor, immunity, due to non-immune, patient doesn't have the proper immune system. See, mainly the immunity, less immunity. Yes, yes, yes. The evidence of genetic factors in asthma is familial clustering. You are marrying within the family, a grandfather and the grandmother, also father and mother suffering from asthma. Children may be suffering from asthma, the familial clustering. High incidence of inbred population, high concordance with the monozygotic twins. Hereditary asthma has a 75%, possibly oligogenic. These are all the genetic factors which is having and leading towards asthma. Again the same thing, types only, like an atopic is, this is atopic is due to allergic, non-atopic immune compromised, then drug induced, patient who are constantly exposed to aspirin. Then occupational, in the sense those individuals who are working in fumes, organic and chemical dust, gases and other chemicals, chemical factories. Pathogenesis, we will go for pathogenesis now. It's a genetic predisposition to type 1 hypersensitivity, acute and chronic airway inflammation and bronchial hyperresponsive. What does it indicate in this sense? We have various hypersensitivity reaction, type 1, type 2, type 3, type 4, like that. In this, asthma comes under type 1 hypersensitivity reaction. How? Type 2, yes, IgE, yeah, IgE. Type 2 helper cells, a type of CD4 helper cells are prominent components of the bronchial inflammation. Okay, just remember, type 2 helper cells and CD4 cells are prominent components of bronchial inflammation. Type 2 helper cells secrete interleukins that promote allergic inflammation and stimulate B cells to produce immunoglobulin E and other antibodies. I will explain you in the picture. Macrophage, CD4 cell, this is the allergen, any dust, any infection like that. Yes, what it does, this CD4 cell, it activates the type 2 helper cells with the help of interleukin 4. This type 2 helper cells, it initiates inflammation, allergic inflammation, and it releases B cells. This B cells releases immunoglobulin E, and then you will be seeing lots of inflammation, eosinophils. Thereby the smooth muscles affected, there is a constriction, it causes bronchial spasm. Now usually this does not follow, actually this has been maintained. This has been maintained by type 1 helper cells. Again the CD4 cells, it activates type 1 helper cells with the help of interleukin 12, and this type 1 helper cells, it inhibits the effect of type 2 helper cells. Okay, it is balanced. If this balance is affected, if only this type 2 helper cells is predominant, there will be an inflammatory reaction and patient will have an allergic reaction. Okay. Now mostly what happens straight away, sometimes from this area it goes to this area and it causes allergic inflammation without going to this type 1 helper cells. How? That is what I said you here. When freed from restraining influence of interferon gamma, type 2 helper cells can provoke airway inflammation. Type 2 helper cells provoke airway inflammation. In patient with allergic asthma, T cell differentiation is skewed into direction of type 2 helper cells. Here T cell directing towards type 2 helper cells. This is the T cell, CD4 cell, directing towards type 2 helper cells without going to type 1 helper cells. Yes. Now one more factor is there to cause this bronchial asthma, that is T-bet. What is the T-bet? A transcription factor, it is known as the T-bet. It is required for type 1 helper cell differentiation, and immunohistochemical studies on lung tissue from asthmaticus level reveal absence of T-bet in lung lymphocytes. In the sense, that is why it goes straight away to the type 2 helper cells. See, CD4 cells, it activates type 1, type 2. Bronchial asthma, what happens? CD4 cells directly it activates type 2 helper cells, it causes inflammation. Yes, and apart from this, this has been maintained by one more transcription factor such as T-bet. T-bet is responsible for this type 1 helper cells. Yeah, it is not there. If it is not there, then this will work, this will initiate only type 2 helper cells. Yeah, a transcription factor called T-bet is required for type 1 helper cells, but if it is absence, it causes asthma. Now airway remodeling, in a sense, this is the microscopy. A persistent structural changes in the airways that include increases in the thickness of airway wall, alteration in the extracellular connective tissue, causes the subbasement membrane, hyperplasia and hypertrophy of resident smooth muscle cells and epithelium, deposition of subepithelial membrane. These are all the 4 features I am going to discuss you. Then one more thing is that ADAM33. ADAM33 belongs to a family of metalloproteinases related to matrix MMPs such as collagen. It is speculated that ADAM33 polymorphism accelerates proliferation of bronchial smooth muscles and fibroblasts, thus contributing to bronchial hyperactivity and subepithelial fibrosis. What does it say here? ADAM33, it is an matrix metalloproteinases. It is a matrix. It is helpful in the healing process. Okay, it is an collagen. Mostly this ADAM33, if there is, it is present in a normal human being, it is for the healing process. It releases the collagen. Okay, it releases whenever there is an injury. To heal that injury, it releases collagen. Then it has been inhibited, and it will become it will be in an equilibrium. It will maintain. But what happens if it is in a polymorphism where it is genetically unstable? Adam33 polymorphism accelerate proliferation of bronchial smooth muscle and fibroblast, thus contributing to bronchial hyperreactivity, bronchial spasm. You got it now? What this is the thing, again the same thing I have mentioned you here. In atopic asthma you will see in the first 2 decades of life allergic manifestation, serum IgE will increase, blood eosinophil count will be get increased. This is the one. Sensitization to bronchial asthma. This is the normal picture showing a lumen, bronchi. This is the bronchial smooth muscles. This is the submucosal glands. Same thing here. This is the lumen. This one, lumen. This is the epithelium. This is an pollen. It's an antigen. When it is presenting towards this, this is the antigen presenting cell. This macrophage which is present over there, it presents to the type 2 helper cells. This type 2 helper cells, it initiate this eosinophil with the help of interleukin 5, as well as it releases type 2 helper cells. It causes the B cells to release more amount of antibodies, IgE. So this IgE antibody in turn it activates the mast cells, and then mast cells it recruits more amount of eosinophils. That's why in blood count you will see in who is suffering from bronchial asthma, you will see lots of eosinophils and antibodies IgE. Now further continuation of this, what happens next? This is the I said you, this is the lumen. Yes, now the spasm starts here. Now you can see this is the basement membrane, this is the smooth muscle, okay? Yes, and thereby there is a constriction of the lumen. Now what happens? Immediate phase, you can see the smooth muscle. This is the increased amounts of eosinophils. This is the vessel permeability. It causes edema. These are all the antibodies. So in the epithelium here, you can see this epithelium. From here, the epithelium is damaged now. It causes mucous material. That's when bronchial asthma will have a mucous material. So you can see the mucous material over here. This is the antigen. Late stage, you can see complete mucus in the whole epithelium, and you can see lots of neutrophils. Okay, this is a microscopic picture. This microscopic picture only I already said you. Oh, sorry. This is the one. Thickness of the airway wall. Hyperplasia, hypertrophy of the smooth muscle, deposition in the subepithelial membrane. Hyperplasia of the smooth muscle, deposition of the subepithelial membrane, thereby there is a constriction. Now intrinsic factor. Till now we have studied about extrinsic factor due to allergic. Now we will go for intrinsic factor, such as patient having a viral infection, air pollutants, due to exercise, and due to aspirin, due to unknown causes. Most of the time there will be bronchial asthma due to unknown causes. We don't know it. In virus, mainly to virus, it induces inflammation of the respiratory mucosa, lowers the threshold of subepithelial vagal receptors to irritants. So inhaled air pollutants such as sulfur dioxide, ozone, nitrogen dioxide may also contribute to chronic airway inflammation and hyperactivity that are present in some cases. These are all the virus, and this is the air pollutants. Infection, any infection, bacterial infection, viral infection, it causes hyperactivity of the bronchial smooth muscle, which causes bronchospasm. This bronchospasm causes edema, causes these 3 features: dyspnea, cough, and wheeze. Air pollution such as sulfur dioxide and nitrogen dioxide also causes hyperactivity. Aspirin, these are all. Yes. Adam33 in intrinsic, in extrinsic, in extrinsic due to allergic. Yes, allergic. Very good. Drug induced. Now the aspirin triggers asthma by inhibiting the cyclooxygenase pathway and arachidonic acid metabolism without affecting the lipoxygenase route, thus tipping the balance towards elaboration of the bronchoconstriction leukotrienes. What else it does? We have studied now. One is yes. We have studied now extrinsic asthma due to allergic. The intrinsic is, you can see that drugs, air pollutants, or due to virus. Okay. In drugs it is aspirin. Aspirin in larger amount, those individuals who are, we will give aspirin for an myocardial infarction, having an angina, who is having a high cholesterol, to prevent from the myocardial infarction. So patient taking aspirin for many years, what happens? It causes a bronchoconstriction. Why it causes bronchoconstriction? In the sense, it triggers asthma by inhibiting the cyclooxygenase pathway of arachidonic acid without affecting the cyclooxygenase route. So it is an pain mediating. You can see that it arachidonic acid pathway in your studied in first year. You just remember that's a big process. You just remember aspirin, it causes a bronchoconstriction of the smooth muscles, long period. Morphology will go now. Morphology is, you can see a gross hyperinflation with small areas of atelectasis, nothing but atelectasis is some kind of a destruction of the lung. You can see the mucus plugs in the bronchi and bronchioles. Microscopically you will see Crushman spiral, Charcot laden crystals. This is the Charcot laden crystals you will see in sputum, and then the Crushman spiral. This is the Crushman spiral. What you are seeing is the epithelial cells which is be shedded in the sputum. I showed you in a previous lecture. This is a Crushman spiral. This is the lung. This is how it presents in bronchial asthma. Hyperinflated. Huh?
Should be equal to the mucus.
Yes, really mucus. And you can see this is the bronchi and bronchioles. You are seeing it is, what does it shows here? It is constricted. In bronchial asthma, it will be, lumen will be constricted. Yes, wall will be constricted. How it will be? My asthma, micropathologies, edema, you can see edema, hyperemia, and inflammation of the bronchioles. You will see in eosinophils it will be increased. You will see patchy necrosis, increased basement membrane. There will be increased size of submucosal glands, hypertrophy and hyperpressure of bronchial smooth muscle. This is the microscopy. This is the one. This is the normal picture. Normally you will see this is the this is the minimal amount of mucus, epithelium. This is the basement membrane, the lamina propria, smooth muscle. These are the glands. This is the cartilage. Normally, this is in bronchial asthma. You will see lots of eosinophils with mucus, with the goblet cells, thickening of the basement membrane, lots of macrophages and eosinophil, then smooth muscle hyperplasia, and the glands also it is increased in size. Yes, intrinsic, extrinsic same, morphology same, only the pathogenesis it differs. Okay, just I showed you in the previous slide, this is my in practical session. Alveoli, this is a bronchi, this is the smooth muscle. Yeah, smooth muscle hyperplasia. This is constriction of the lumen. Again, this is the lumen, these are all the smooth muscles. Okay. Clinically, patient will have a dyspnea with wheezing, last 1 to several hours. You should give treatment of bronchodilator, steroids. Patient with stated asthmaticus, there will be increased chance of death. Yes. This is about the summary of this asthma. You can see here, eosinophils are the key inflammatory cells found in almost all subtypes of asthma. Eosinophils, products of the major basic protein, are responsible for airway damage. Okay, these are all the things just now we discussed about type 2 helper cells, type 1 helper cells. The last one,